Welcome everyone. Thank you for joining us. We're here with Nancy Lush from Patient-Centric Solutions and Dave Hill from MITRE, and they're going to tell us about PACIO. Thank you very much. Oh, please, for everyone online, please ask your questions in the Whova Q&A. We will ask them at the end. I will bring them up together with questions here from the audience. So if you raise your hand in Zoom, we're not seeing that. So please put your questions in the Q&A. Thanks.
Okay, so to start with, we'd like to learn a little bit about our audience. So please, with a show of hands, let me know how many people have either clinical or medical background in the audience.
Awesome.
Great. Okay, and of those in the audience, how many are more of a technical background?
Great.
Okay, great. And so this applies either to you or perhaps a family member. How many have had experience traveling, traveling through a transition of care situation where someone's admitted to a hospital, perhaps released to a skilled nursing facility, onto home health care, or perhaps a long-term care facility? Great. All right, and how many in the audience has had trouble or challenges trying to get your medical record to a new provider? Pretty much unanimous. Great, thank you. So go ahead, Dave.
All right, so thanks everybody for being here. So what we're going to cover today is some of the background of post-acute care and why it's important, what information needs to be exchanged, and why there needs to be the PACIO project. We're going to talk about some of the PACIO project use cases, and then we're going to dive into what we did at the May Connectathon with our PACIO integration track. We'll do a demonstration, or actually Nancy will do a demonstration of her work, which is really exciting. And then we'll wrap up with some PACIO project resources. And if you're interested in all of this, please join our effort. So post-acute care is really important because 45% of Medicare patients that leave the hospital go into some form of post-acute care. So it's a huge part of our healthcare system, and there's about 74 billion.
I'm not showing you slides.
Oh, slides are not showing. Oh, there we go. Great. So that costs over $74 billion annually. So it's a huge part of our healthcare system. So back in 2014, CMS passed the IMPACT Act, which standardized patient assessment data elements at a variety of post-acute care facilities like long-term care hospitals, skilled nursing facilities, home health agencies, and inpatient rehabilitation facilities. And this is really a cornerstone of some of what we've been doing with our work for CMS as well as with the PACIO project. And then back in 2018, the CMS created the data element library. And what this does, it's a central repository that stores all of the assessments, all of the questions for each of those assessments, and potential responses. And so it provides a standardized way for you to get all this information. And because they're all standardized, it allows this to be much cleaner data for analytics purposes as we move from information to understanding and being able to analyze and understand what the data means to the wisdom of maybe doing predictive analytics in the future. So this is really a cornerstone of some of the work that's being done. So there's a variety of different assessments for each of the various different PAC settings, and all of these are in the data element library. There's over 250 different assessments in there of different versions and so forth, and you can visit it by going to del.cms.gov. So the PACIO project builds on this, and we've been following this patient story where post-acute care patients are some of the most complex patients in our healthcare system. They have usually multiple stops in their healthcare journey, and they typically go a lot of times from place to place to place. And that means that every time that transition occurs, that communication can be dropped. So there's often very poor communication between these care providers. There's a heavy reliance on patient recall, which is not always reliable or even possible because they may be unconscious. And then there's increased cost and burden. A lot of times if the patient isn't receiving the care after a transition they need, they go downhill pretty quickly. And a few days becomes a few weeks or months. And also the providers have to dig up this information. They have to actually look to try to fill in the gaps, and that takes time. The PACIO project was started in 2019, and we have a variety of great folks involved. We have EHR vendors, we have other vendors, we have government agencies, we have consortiums representing a variety of different clinical areas and so forth. And so it's a really great group. They bring a lot of different perspectives to this and really helps move our work forward. So the PACIO use cases, we've been focusing really on 5, arguably 6 different use cases. We have functional status and cognitive status. Those were our first 2. Those have been published as STU1 standards. We also have advanced directives and reassessment time points. Those are in ballot reconciliation at this point. And then we have SPLASH, which is speech, language, swallowing, cognitive communication, and hearing. And that is being under development at this time. All along the way, we've been sort of cross-cutting these with quality measures and calculating quality measures from that at some of our connectathons. As we've moved through this, we've seen that there's a common data structure that sort of has come out of this. And so what we are doing is we are combining functional status, cognitive status, and SPLASH into a new functional performance IG. And we'll talk about that in a minute. Here are the various use cases and timelines. Functional and cognitive status are pretty much done for STU1. Functional performance is a relatively new piece where we're adding the speech, language, swallowing, cognitive communication, and hearing in that. We also have been working on advanced directives. That's a two-prong approach. So STU1 is in ballot reconciliation right now. STU2 is in development. We'll talk a little bit more why that's the case in a bit. And then we're also talking about reassessment time points, which are also in ballot reconciliation. So one of the things that, as we've gone through the various use cases for PACIO, we've looked at what the Gravity Project is doing, because they have a similar problem. They have like 20 different use cases, and they all of the information is similar in its data structure. And so they, instead of having 20 different implementation guides with each with 10 different profiles, that's just overwhelming. So they've decided to consolidate that into the social determinants of health clinical care implementation guide and define healthcare domains for each of these areas. And that's what we're doing with the functional performance. So with functional performance, we have the same kind of problem, maybe not quite yet to the degree of Gravity, but a lot of different areas where these are all to a large degree observation-based, and the structure of the data is the same. Really, the only difference is the code systems and value sets that are used for each one of them. So we are using the ICF, which is the International Classification of Function, Disability, and Health, to create categories to allow us to categorize that information and specify for each of those categories the value sets and code systems that we want to use. And so what we've been doing is working through the various different code systems that are available in VSAC, looking at the International Classification of Function categories, and then tying the various different pieces of information that we want to capture in PACIO. And in this case, this is a SPLASH example, but the functional communication measures, tying those to each of those different areas so that we get sort of this complete tie-in of what you're trying to capture, what the category is, and what the underlying code system and value set is. So next, I want to talk about advanced directives. So advanced directives, as I mentioned, we're taking a multi-pronged approach. In STU1, we're looking to focus on person-authored information across all the various different use cases here, being able to create the advanced directives, to share it, to query and access it, to update it, and to make sure you have the latest version of it. And then for STU2, we're looking to focus more on practitioner-authored information, such as portable medical order for life-sustaining treatment and encounter-centric patient instruction. So this is the data structure that we put together. On the top level is a bundle, under that is a composition, and then various different sections across that comprise the various different components of an advanced directive with all of the underlying data underneath it. And there's a variety of different types of FHIR resources that we use to do that. For reassessment time points, encounters are a little different in post-acute care because encounters can last for years. And so if you want to pull in all of the information for an encounter, you get deluged with potentially multiple years of data. And so what we've done is we've added this thing in the middle called a reassessment time point, which breaks up the encounter into smaller pieces, adds a different organization level so that you can focus on individual areas of time. So with all of that background, this is where we start to bring it all together for what we did at the May Connectathon. And so at the May Connectathon, we actually demonstrated 9 FHIR IGs working together throughout a big use case. And so not only the 4 that I just mentioned, but also several additional implementation guides as well. We were able to show that we could create, exchange, and query that information across a variety of systems. We tested some new things with the SPLASH IG, particularly around hearing and multimodal communication. And then we also tested the new PACIO FHIR functional performance ID to make sure that the ICF framework that we were using was going to work. We had 23 different participants. These are all really great folks to have on board. They all provided different roles, and it was a pretty successful Connectathon for us. So we had, again, the 9 different implementation guides. We had the 4 PACIO implementation guides, but we also included the Gravity Social Determinants of Health Clinical Care implementation guide, the Electronic Long-Term Services and Support Care Plan implementation guide, the Multiple Chronic Conditions eCarePlan implementation guide. Plus, we also added a couple of coordination IGs, the Da Vinci Data Exchange for Quality Measures IG, as well as the Patient Data Receipt IG, which is being developed as part of the Open Health Manager project at MITRE. With that, I will hand it over to Nancy.
Yeah. So a couple more, thank you, Dave. A couple of the other things that we demonstrated this May Connectathon was we interacted with Gravity. So of course, you know, Gravity sponsors the SDoH domain. And in their demonstration, they recognized that Betsy, our patient Betsy, had these transportation needs to get to her appointments. So they actually issued a service referral for her transportation. And then they demonstrated how someone received that referral and provided the service for her transportation. We've actually been involved with this long-term services and support IG for more than several years with the PACIO group. And they really focused on supporting the healthcare and community-based long-term services. So for this particular Connectathon, in our use case, we followed this for the Gravity example, and so Gravity recognized she needed transportation, so we added that new additional service to her long-term services plan so that she had recurring services for transportation to meet both her appointments and some other personal needs. And this is, of course, the ELTSS data set. You can find all this online. We also integrated with the MCC eCarePlan, and this is really focused on multiple chronic conditions. And it's really a plan for multiple care team members, and not only the various providers, but also the patients and their caregivers. And the PACIO group for this particular exercise worked with the MCC eCarePlan team to integrate their data into our PACIO use cases. And part of our learnings, which Dave will tell you about, was what it looked like when we decided to bring all this data together into one longitudinal record. So now let me tell you a little bit about Betsy. So our patient Betsy is 70 years old. She lives in Texas, is recently retired. She has an adult son, Charles, who's designated as her healthcare proxy and helps her, when she needs it. She's also considering moving to Michigan where her son, Charles, and his family currently reside. She's on Social Security, and she's currently getting her healthcare coverage through Medicare. So as you'll see when we do our demo, she has multiple chronic conditions. She suffers a stroke. She's admitted to the hospital, so she has a chronic incident of care, and you'll see her transferring through the different facilities, and you'll see how her data flows with her. So when we think about this, what's required for Betsy's care to go smoothly? At each stage, her doctors need to know what came before, and that's critical. So often when we go across transitions of care, that data just simply isn't available. Assessments need to be shared across facilities to understand her improvements. And we have doctors, physical therapists, nurses, family members, all these people need to understand Betsy's wishes and her personal goals. Betsy herself would like to track her own activity, and she'd like to help coordinate her own care. And she'd also like her son, Charles, to be able to carry out her wishes if she's unable to convey them or speak for herself. And I'm going to give that back to you, Dave.
Yeah, so our use case involves many different scenes. So in scene 0, there's a lot of the collecting of preliminary information, particularly around recording her care preference details. In scene 1, she's able to care for herself at home with the assistance, but her hearing's been getting worse, and so she's been evaluated for hearing aids. In scene 2, Betsy experiences right side weakness and slurred speech, so she's treated for a stroke at the hospital. She progresses at the hospital, is discharged to a skilled nursing facility, and she continues to receive long-term care there in her stroke recovery. She continues to improve and is discharged to home health agency, and she continues her stroke recovery there, but her diabetes flares up, and so she's going to need additional visits with her doctor's office, and she's going to need help with transportation. And so this is a fairly complex scene. There's 4 actually separate scenarios within this scene that we broke out. In scene 5, Betsy has now completed her stroke recovery and wants to visit her son Charles, and so she goes and visit him and his family for an extended holiday event. And while she's up there, she decides to update her advanced directives. And in scene 6, she decides that she's going to be spending more time in Michigan, so she wants to put together, have a personal care physician, PCP, or primary care physician up in Michigan. And so therefore, she's establishing care there and allowing that PCP to access her records. So this is kind of the overall scene diagram. And so there's a lot of different roles and a lot of different systems involved in this. And so, you know, these are all of the things that we tested at the Connectathon. And I will turn it back over to Nancy to talk about the Health Data Manager.
Okay, so so one of the things that we've introduced in the series of Connectathon over several years is this Health Data Manager. And initially, we really just needed a common FHIR repository where we could read and write data in order to exchange the data. But then, as this concept evolved, it became more of a patient-centered repository where we have a really complete patient record that travels with the patient across the continuum of care. So you can imagine if data is always written to this common health manager, all that data is available and up to date at every point in care. So the benefits of this shifted paradigm soon became clear, as all care providers had access to really complete, accurate clinical records at the point of care, both improving outcomes and reducing costs. It also enabled the ability to share data, so not only sharing it with the different providers, but also sharing it with the patient and family as well. And prior to our first introduction of this data manager at the Connectathons, most people were doing FHIR read. They weren't doing as much FHIR write, and we really needed to be able to support this read and write. So that certainly was one of the key pieces. So the PACIO work demonstrates not only read and write to a health data manager, but from various other systems. So a lot of times we'll, like a PAC assessment will write to a EHR, then the EHR will write it to health data manager. We really have data flowing all over the place, as you'll see in the next diagram. So under today's known paradigms, this type of feature really could be provided by an HIE, if an HIE would do that. It also could be provided to high usage patients, such as Betsy, or anybody with multiple chronic conditions who is going through a transitions of care use case, and anybody who is really kind of high use and, as a result, high cost. Currently, patient data tends to be siloed in different organizations, as we all are aware, and we expect to receive many benefits by having one longitudinal patient-centered record, really encouraging patients to engage in their own care. And this, again, is more of the detail of what we did in the September Connectathon. It's quite a bit of detail here, but as the various scenes that Dave mentioned all flowed in and out of the Health Data Manager. The next slide is yours, Dave.
Yeah, so as we went through, we tested a variety of systems and a variety of different roles. We had successful tests in almost all of them. The multiple chronic conditions team, we had difficulty actually scheduling between, they have their own separate track, and so we had some difficulty there. So we weren't able to test as many things there, but everything else we were able to have successful tests on. And they have, the multiple chronic care people have really, great demos too. We just weren't able to do it at the Connectathon. So just for quickly running through some of the scenes, for the hearing data, we collected the splash observations, and then through our pseudo EHR, and then through patient-centric solutions software was able to display that information, including the individual test information, as well as doing a trend analysis on that as well over time. In scene 2, we started with, this is when she has a stroke, so there's a patient PAC assessment application, which draws from what we call a pseudo-DEL. We took the public information from the data element library, put it into a happy server, put a FHIR API on it, and so now you're able to pull that information down through FHIR, display the form, and this through a single piece of code, we can display 250 different assessments in the PAC assessment app. So this takes that data, puts up the form, the clinician fills it out, and then patient share by patient-centric solutions is able to display that information successfully. And so this really shows a full system flow. We have this pseudo-DEL, which provides a structured data capture questionnaire instance to the PAC assessment app, which displays the form. The form then collects the information, creates a structured data capture questionnaire response, and hands that off to the EHR. The EHR takes that and blows it up into functional performance collections and observations, so that it's much easier to query that data. and puts that in a bundle along with the questionnaire response and stores that in the health data manager. So it has all of that information for further folks down throughout the scenario. And then the patient or clinician app can then pull that information and display it as appropriate for the audience. In scene 3, this is the reassessment time points. We created a reference implementation to do this and showed how the reassessment time point could be tied to the clinical impression and then tied to the various different assessment details below that. In a previous Connectathon, we had and through the home health, we had Matrix Care do the same thing. Matrix Care also created a post-acute care collection application using the pseudodel, and then was able to collect that information and put it into reassessment time points. And MaxMDs, they had a mobile application which was able to display those various different reassessment time points. And patient-centric solutions was also able to show those different reassessment time points, and you could select an individual one, see the assessments underneath it, and even see the trends within that reassessment time point. And then in scene 4 and A and B, we brought in the electronic clinical quality measures and the transportation needs. So in this case, the Gravity was able to show a transportation referral and how that you could monitor the status of that referral and then how it could be eventually fulfilled. And so that showed the workflow there. And scene 4C and 4D, we have the eCarePlans. And so Alterum was able to show the capture of that care plan and display of the care plan, and then patient share from patient-centric solutions was able to show how you could get access to all of those care plans for the patient. And then also in scene 5, this is showing some of the information we collected in scene 0, the living will, and we were able to show a scanned version of the living will so that folks in the future could see that. But also, we were able to show how we can create FHIR-based documents using our Advanced Directives Implementation Guide, converting consolidated CDA information over into FHIR. And so that was done by AD Vault. And so we were able to then show that in the MaxMD mobile application, which could show all of the various different pieces of that advanced directive. And also up in Michigan, we were able to show that we were able to update those advanced directives using the transitions of care software from patient-centric solutions. So we were able to show all of that information as well. And then in scene 6, when we want to share that all this information with the new primary care physician, again, through patient share, by patient-centric solutions, you set up consent so you can see that Betsy has consented to her son Charles and her daughter Deborah, but also now is adding Dr. Erica Physician, her new PCP up in Michigan, and she can specify what type of data she wants to share with that person, and she can revoke it at any time. So with that, I will hand it over to Nancy for a demonstration.
Okay. Sorry. All right, so I'm going to be doing a presentation today using our software, the Patient Share app, but I really like to point out, as Dave just demonstrated with his many slides, we had many stakeholders involved, and we had great partners involved in every aspect of this. And of course, the point of FHIR is that any app could be creating the same, conforming to the same specs. So ultimately, you could kind of swap one app in and one app out. So we are using ours today to show all the various pieces, but I can't state enough that we had those wonderful stakeholders all involved. And for the last May Connectathon, I want to give a complete, particular shout out to AD Vault, MaxMD, Matrix Care, Alterum, Abacus FHIR, MITRE, and the various projects, the LTSS, the MCC, eCarePlan, and Gravity projects. So obviously everybody was very involved in all of these. So I'll start with, we have a simple demographics record, and actually some of this data came from different IGs. So in this case, the Betsy, our patient Betsy, also has an adult son, Charles, who's also her guardian and her emergency contact. She has another adult child, her daughter in this case, living in a different part of the country, but Deborah's just as interested in her care as the brother, and she also shows her insurance coverage. I'm not going to be going through each one of these resources, but let's jump down to the conditions. As you can see, this patient has multiple chronic conditions, and she has a number of things going on. And similarly, in her medication, is kind of indicative of the load that she's carrying. She has a fairly complicated medication regimen as well. So let me jump down to some of the more specific things that we did in this IG. So the assessment, as Dave talked about, was one of our key focuses. And this particular assessment panel shows all three of our IGs, both the functional, the cognitive, and also our speech-language pathology. And what happens, I don't know if Dave mentioned, and we talked about the roadmap slide. At each facility, they need to do these assessments at least twice. So once at admission, once in discharge. So twice at the hospital, twice at the skilled nursing facility, twice at home health care. If they're another facility, twice again. So it's really important that all this data gets conveyed to every person along the continuum of care, and what happened before is important. So I'm going to drill down into one of our first assessments, and then I'm going to come back a little in a bit and show you the rest of the assessment types that are included here. But to give you an idea of what this looks like, this is the first assessment on admission to the hospital. So we know the organization where it occurred, the location, and who did the assessment. We know what the particular assessment instrument is. And there's a number of different questions here, and I won't go through all of them, but we talk about her ability to roll left and right, her ability, to do a car transfer, walk a certain number of feet, and all these questions, and they all change over time. So we can see here that initially she needed maximal assistance in this ability to roll left and right. Now, it's really great that we have FHIR and we can make all this data available across facilities, but there's a lot of information here as well, and sometimes a little bit difficult to dig through. So one of the benefits of FHIR is all this is stored as discrete data elements, so we can pull it together in more of a summary. So this is an example, this is an example of all of the data kind of twisted and shown in a different way. So each one of these columns indicates a different facility, and down the left is the kind of the granular level of each question. So I'm going to focus on this ability to move left and right. Admission to the hospital, she needed maximal assistance, and then it kind of got better over time. And then we see that when she's actually discharged from home health, she's actually independent, and we show the graphs and the trends of that data over time. So this is very meaningful to anybody providing care along that continuum. Let's see, and so giving you the overall of the kinds of assessments that we covered in this, we had the functional assessments. Under functional, we had mobility, and as Dave mentioned, there are many different other assessments. These are the ones we just happened to cover in the Connectathon. We had a grouping on self-care. We had a prior level of function. Under cognitive, we had the cognitive status. We had BIMS, the PHQ-9, MOCA, and I think MMSE, and then within, this is one of the newer IGs with the SPLASH IG, and it goes through the various hearing, communication, ingestion functions. And again, all this data is available along with the summary information to inform care. Okay, so one of the other IGs that PACIO specialized in was this advanced directive. Actually, I'm going to jump over to this version of this plan. So this shows, an advanced directive, and we see, the details, of course, about Betsy, who the custodian is. So this plan was created by a company called AdVault through their product My Directives, and they're the custodian of the data, and it can be exchanged across care facilities. Betsy has appointed 2 healthcare agents, both her son Charles and her adult daughter Deborah. She has a number of goals, and these tend to be care plans, but the goals around her priorities for care. So there's a couple of examples. She loves the smell of lavender. She doesn't like her feet to be cold, that level of thing. We also have a number of other preferences. So these are under certain conditions. So this plan addresses the situation when she's either unconscious or in a coma or something like that. So her personal goals would be to avoid prolonged dependence on machines. She doesn't want to be a physical burden to her family, and she really prefers to die at home. And it goes through the various other related, specific related things that are important to her around that use case. And we have the next plan where really she has either permanent or severe brain damage. She's really unable to recognize her family and friends. Some of the goals are similar as they were for the other case, but again, they can be unique depending on what this particular patient's goals might be. And then we have a last case where she addresses her situation for terminal illness. Again, some of them are the same. They want a little bit more information for that particular use case. And then she also has preferences about how to handle the situation upon death, right? So if she were to pass away, call my lawyer, Jim, he has all the information, but we need to have certain information available, at that point in time. So, her ability, her wish to donate all of her organs and tissues, and regarding an autopsy, she's going to leave that decision with her adult son, Charles. Additionally, we have the witness and notary information that accompanies that. All right, let me go back here to care plans. We're okay in time, Dave. So we have a couple different care plans. I'll start by showing you the ELTSS care plan. Again, we've worked with this one quite a few times. It's a great, rather than so much clinical care plan, it's more long-term services care plan. And it focuses a lot of patients' goals. So in this particular instance, you saw how many conditions Betsy had. She had a pretty complicated history that the doctors are worried about. But the thing that's driving her is that her daughter's getting married soon. She wants to be able to dance at that upcoming wedding. So that's really her goal, and we want to keep that in mind as we're providing services to Betsy. But this goes through the various services. There are different waiver programs, and a lot of this is available through CMS. And it shows what the services are, the costing, and the cost over time, and who's providing each one of those services. We have signatures for the various people involved. We also have a kind of assessment questionnaire at the end and her risk assessments. So with that one, and we also have our MCC care plan. So this is, again, one that was contributed, the data was contributed by the MCC work group. And incorporated into our PACIO use case. So she has a number of goals she's trying to address. So they're trying to reduce her blood pressure. She's also trying to stabilize her A1C for treatment of diabetes. So it talks about the different services that this addresses, and goes through with the specific services that are provided to achieve the goals that we've defined. Again, the care team member. This is another interesting example. So this care team came out of the the care team came out of the care plan IG, and then it shows up again as care plans. We could have multiple care plans depending on what's going on with this particular patient. All right, I think I've covered most of those. So lastly, we also provide a summary, and this is kind of a configurable piece where we can pull in the appropriate pieces that make sense for whatever these users might need. But one of the new things that we did in this particular Connectathon is we implemented quality measures. So earlier in our story, if we looked at our quality measures, Betsy's diabetes was under control, her A1C was in range. And now we're going to just check her quality measures here towards the end of our story, and we can see that with all the things going on in her transitions of care, her A1C is beginning to shoot up. So what's happened here is we've taken data from the FHIR record, we've hit an external server that hits that eCQM server, and we've basically come up with a gap, we've identified the gap, we've tied that together with Betsy's individual readings out of her lab results, and we've kind of highlighted to the user that of the various things that we're looking at, this is something you might want to check. So that's pretty much the summary. Did I miss anything? Back. Go.
All right, thank you, Nancy. So what did we learn? So we've been, one of the things we learned as we brought all these things together is that care plans and conditions, particularly around advanced directives, there was still some more work to be done there. We had some of the advanced directives conditions showing up in our condition list. So you would see diabetes and chronic kidney disease, and then you would say, if I'm in a coma, then this stuff, I want this stuff to happen, which really doesn't belong there. So we're working to make that clearer in the implementation guide of how to treat that data. The other thing is that we have, as you've seen, multiple care plans, and will probably be a lot more as we go forward. And so how do you harmonize and bring all that together? I mean, and that's going to be one of the things that I think we all have to think about, how we do that. The third thing is harmonization of codes. We had, and this is kind of sort of a legacy thing within post-acute care, I think, but there's a lot of different codes that mean the same thing. So we've got 5 or 6 different codes for, for walking 150 feet. So when you're doing analytics, that's really kind of makes things a little more challenging because you've got to now map those things together. The other thing, of course, is ICF. We need to get more official support for ICF into FHIR, and that's something that we'll be working on. So the notable achievements here is we had 9 different unique IGs across over 20 different systems, and we were able to show how we could exchange all that information. We had over 800 resource instances, so a lot of sample data, as Nancy showed in the demo, lots of information there. We also integrated pretty extensive IG changes from previous Connectathons, particularly around the functional performance IG. This was really the first rodeo for that IG, and it worked out really, really well for us. And then we were showing how we could merge all that data and put it into a single data repository, or the health data manager. As I mentioned, we did successfully test the functional performance IG, that not only for SPLASH, but also for functional status and cognitive status information. And we also demonstrated how, in the proof of concept, of how the information could all be stored and retrieved from the health data manager through a central location. So what's next? So we want to share what we've learned here, and so this is part of the process of doing that. And also we want to look into how we can resolve some of the multiple codes for the same concept. So we'll be working on that. We were looking for pilot opportunities. So if you guys, any of you out here is interested in piloting this stuff, we would love to hear from you. And also, I think there's long-term collaboration things that we can look at here. Like, it's a pretty big paradigm shift to have a central health manager. And so what does that mean to the healthcare ecosystem, and how can we adopt that? So, and that's what we're looking to continue that conversation on. We meet several times a week. I won't go into the details here. We also meet with a number of HL7 sponsors and co-sponsors for our work, and we very much appreciate their input on what we do and helping guide us. There's also, we've got websites and Confluence pages. The Confluence page has all kinds of data of what we're doing, all of our meetings, all of the notes, everything. We have a GitHub repository of now close to 30 different repositories, as well as a YouTube channel for our demonstrations. And we'll be adding to those as we go forward. So I want to thank you all for attending. I just wanted to finish up with a brief story. Nancy might have a little bit more to show. But I wanted to share a story with you. One time I was driving my car up to rural Maine, and on the way up there, my alternator died. So fortunately, I was close enough to my destination so that I got there before the battery died, took it to the local shop. They fixed the alternator, no problem. I walk in there to pick up the car, and they say, oh, by the way, you realize you're overdue for a timing belt change? I said, no. How did you know that? I said, well, we looked it up. I said, okay, so I'm in rural Maine. They know that my car needs a timing belt change. But if something happened to me, I can almost guarantee they would know absolutely nothing about me. So I want what my car has. So.
All right, I'm going to do one more quick little demo that I forgot to do previously. Probably take about maybe 2 minutes. Okay, so I meant to show you this at the end of our demo, but this is an example where we have Betsy, who has access to her data, and she's going to be sharing it with another provider who is outside of the network and doesn't currently have access. She's going to first of all log in, and we actually have this concept of a trusted identity, which we could log into, or an organizational identity. We are going to log into the organizational identity, but I'm looking at Ryan out there in the audience, and kind of a nod that the Karen Alliance is also working on trusted identity paradigms, which is very important to be able to exchange data across facilities. So this is an example of a dashboard. So of course, Betsy has access to her own data at any point in time. She also has this kind of consent system, and she's created consents to share with her adult son, Charles. She can either share all of her information or some subset of that information. She can revoke it at any point in time. And in this particular use case, what we demonstrated at the Connectathon was she created a new consent to share with a new physician as she moved to Michigan to visit her son. So she needed to transfer all of her records from all of her care providers in Texas to Michigan. So she did create this consent, and that provider was then able to log in and access her data. Additionally, we have a transparency feature that shows not only all the current consents that she has when they were created and what the status is, but we also we actually record whoever's accessed her data and what aspect of the data that has been accessed. So there's complete transparency to the patient of who is actually accessing her data. So that was that, and I think we're on to questions now.
Thank you for, yep, there we are. Wonderful, thank you for your talk. Very nice. I see we have a question already here from Gustav.
Thanks. So yeah, really interesting. So from the point of view of data compatibility of the providers, so I'm not sure, do they all have to comply to a specific standard, and do they comply to that standard, or how would that work out? So do you have to do a lot of transformation, aggregation, cleaning of the data, and for that to work?
Yeah, so I think in the Impact Act really requires at least the post-acute care facilities to standardize their assessments, and that's a big step forward. And that was passed and all of that. The data element library helps provide that right now on a web interface. So like a web application, you can look up and get information about how the various different assessments should be addressed. So that's a huge step towards getting that towards standardization for as far as assessments go. It's the hope that the work that we're doing, particularly around the ICF categorization, to allow to provide very clear, hopefully very clear guidance on, okay, if you're wanting to exchange this type of information, so mental status or whatever, these are the code systems and value sets that you want to use. And we want to try to be as specific as we can about that so that you have the semantic interoperability between various systems.
Hey, Dave, great progress. You guys are doing great work, and Nancy too. Question is, was this used, the self-reported FHIR questionnaire, to try to do the advanced directives? Is that what you guys use for the FHIR API, for doing advanced directives? Did you do FHIR questionnaire to make that happen?
Yeah, so actually that's the one that we used was created by AdVault, who has a system for advanced directives. And then that AdVault data was transferred to a CCDA, and that was then converted to FHIR.
When you converted it to FHIR, was it the questionnaire that you converted it to? FHIR questionnaire resource?
It came from, well, there's no questionnaire resources in any of the aspects of that ID.
Yeah, so it's more of what we showed up.
This was actually a pretty complicated IG, I think one of our most complicated.
So it's basically with taking on this data structure where you have the top level of a bundle, and under that a composition. And then in the composition, there's the various sections for healthcare agent, quality of life, experiences, end of life, goals, preferences and priorities upon death, additional documentation, witness and notary, and administrative information. And under that, there are all these goals, these care plans, there's consent, there's clauses, and so forth that are all included in that. So it's a whole bunch of different things combined. I'm not aware of them using questionnaire at this point.
Okay, and then the other question I had was, did you find any overlap between the Dell FHIR API? Because I know data element library is really for CMS, right, to report that information into CMS. Mm-hmm. Did you find any overlap between that and the digital quality measures? And are there fields that are within the reporting structure that needs to be sent to CMS that are also applicable on the quality side?
Yeah, so there are two different paradigms between right now and between post-acute care and the rest of healthcare to some degree with the quality measures. And so we've been in discussions, about that and trying to resolve that and bring that in together. So that's a process that's still in place. Okay,
last question, sorry. The post-acute care vendors, did you have any of the post-acute care vendors in home care, home base, or any of the other ones that are involved in the Connectathon?
Yes, particularly Matrix Care. But we also now, Point Click Care is attending regularly. And so those are the two primary major EHRs in the post-care community. Hi.
Hey, great presentation, thank you. Wondering if it's come up at all, the collection of wearable data, because I know that, in post-acute care, more and more with home hospital, people are going to devices that can monitor the patient even in their home. And I would think that collecting that as part of those assessments that you talked about might be something that might have come up.
Yeah, no, it's definitely come up, and it's something that we have talked about. Unfortunately, we're a limited organization. We don't have a whole lot of, we have a reasonable number of people, but we can't tackle too many use cases at once. But that is definitely something that we've talked about, and I think it's a really critical part. it provides that real-time information that I think is very useful.
Awesome. I think we're on time, but maybe I can squeeze in one question for myself. So is this, you think US realm specific, what you're working on, or?
It is US realm specific. We are trying to keep, to some degree, as much as we can, international as well in mind, but because this work is being funded by CMS, and so by that nature, it's US realm. But, we've certainly are always looking out to see how we can make this work for the international community.
Yeah, and the ICF is actually.
Yeah, the ICF is a big step in that direction.
Yeah, that's actually underwritten by WHO.
So.
Wonderful. Well, okay, one more then.
One quick follow-up question to that, and that was an excellent presentation, thank you. Does CMS have any carrots or sticks to incentivize adoption of this?
Well, I can't really comment on that. Let CMS make their own statements on that. But certainly you've seen other areas like in the Patient Access API where they've put in regulations around payers and allowing patients to be able to get access to their information. So in that instance, it was certainly yes.
Great.
The assessment data does need to be reported to CMS right now. I mean, it
Yes.
would be ideally if we also could share it with other care providers. It's being reported anyway.
Right.
Yeah.
So, I mean, the assessments are being collected right now as mandated by the Impact Act, but they're not being collected via FHIR. They're being collected, through a hodgepodge of different transport mechanisms. So what we're trying to do is make it so that it's FHIR from beginning to end. And that's what you sort of saw there with the slide with the 5 different systems, coming from the data element library all the way through the collection of the assessments to the presentation in Nancy's software.
Great. Let's close it with that. And thanks Dave Hill and Nancy Lush again. And if you want to follow up, the speakers are here still probably
Yep.
available for questions. And online, you can ask your questions in the Q&A still.